Hi, I'm Brian Lau. I'm with AccuSport Education, also with Jingjin Movement Training. We're going to be looking at the anatomy of the abdominal region of the spleen and kidney channel today. And this is part two from a presentation I gave on the stomach channel. So we'll compare the anatomy of the stomach channel with the spleen and kidney channel. So just a little bit of a heads up. I have multiple hats like many of us do. One of my main hats is I'm an anatomist. I lead dissection with AccuSport Education, but also with the University of Tampa physician assistance program. So I do a lot of exploration in human anatomy. So that's the lens that we're going to be looking at as we delve into these fascial layers of the spleen and kidney channel. But of course, all of that gives a lot of clinical relevance. So we'll talk about it from a clinical perspective also. So let's go ahead and go to the PowerPoint. We'll start looking at initially the spleen channel. So I have these additions to Netter's Atlas of Human Anatomy. They don't have the acupuncture points on this like I put these on manually. Netter is just one of the gold standards of anatomical illustrations, and it's just such great illustrations that I thought I would adapt it by adding, in this case, the spleen channel. And as we know, the spleen channel is on the lateral edge of the rectus abdominis. So useful information, but we can talk about the significance of that in just a second. As we travel down to the lower portion of the spleen channel on the abdomen, we have spleen 12, spleen 13 at the inguinal ligament, spleen 12 also, but it's on that lateral border of the femoral artery. So this will be our first window into understanding the depth in the fascial layer that makes up the spleen channel. So keep that one in mind as we go to the next image. So what this next image is showing, also from Netter's Atlas of Human Anatomy, is the arteries. There's another image for the veins. They run together, but the vascular structures of the anterior abdominal wall. First of all, notice that this epigastric artery in the vein, like I said, runs directly with it. That's in a separate illustration for Netter, but that's fine. You get the general idea that it's running along here. That branches off of the femoral artery, or excuse me, the iliac artery in that region where it's connecting with the femoral artery. So it's branching off of that region of spleen 12. And where does it go? It goes deep to the rectus abdominis, behind the rectus abdominis, and that's the territory that it travels. In my mind, this is the Chongmai. This is the vessel that you can palpate on the front. You can often feel a strong pulsation, especially if people don't have good circulation in the aorta. More blood shunts through this area. So it's kind of like a reservoir. It can open up or close up depending on the needs of the body. And it runs and follows the trajectory of the Chongmai. It branches into the thoracic artery and vein, which go to the breast, kind of one of the functions of the Chongmai. Sends out branches along the intercostal arteries and veins, and then eventually it branches into cervical arteries too that go up into the face. So that's the territory that we're looking at for the spleen channel. We'll look at another image in a second on that. Also, the Chongmai follows the kidney channel points. So again, we're looking at a fascial layer that lives behind the rectus abdominis. And that's going to be the deeper yin channel territory of the spleen and kidney channels. So here's the kidney channel points. The kidney channel points are going to be on the medial edge of the rectus abdominis, pretty close to the linea alba, 0.5 sun. And it's going into the rectus abdominis muscle, but my target tissue is not at the rectus abdominis, but that posterior rectus sheath. So when we compare that to the spleen channel on the lateral edge of the rectus abdominis, same thing. It might be into the muscle, but posterior rectus sheath is going to be my target. So this would be an easier image to look at if we can see a cross-section to understand that layer. So here where we were last time, when we looked at the stomach channel is following these fascial layers of the external oblique, a little bit of the bifurcation of the internal oblique fascia going on top of the rectus abdominis. The needle can get into that anterior rectus sheath, maybe potentially into the muscle, but that's the territory, that's the depth, that's the region that I want to address when I'm treating it. Whereas if I'm in the spleen channel or the kidney channel, we're looking at the internal oblique fascia, transverse abdominis fascia that goes posterior to the rectus abdominis. So this posterior rectus sheath. So if I'm coming in at the spleen channel at that semilunar line, I'm into this window of tissue that goes deep to the rectus abdominis. If I'm coming at the medial edge at the kidney channel, again, I want that needle to traverse down to that posterior rectus sheath. So I want to affect this layer here. Multiple importances of that, but one very simple one is if I look at this bigger cross section, rectus abdominis, spine, erector spinae, quadratus lumborum, is that fascial layer is continuous with the transverse abdominis and the internal obliques, and that's going to continue to come into a seam at the thoracolumbar fascia at a structure called the lateral raphe. And that lateral raphe is going to separate into a deeper layer that goes between the quadratus lumborum and erector spinae, and a superficial layer that goes above the erector spinae. So point is when I'm treating this deeper fascial layer, I'm speaking to, communicating with the musculature like the quadratus lumborum and erector spinae. So there's a lot of fascial communication between the front and the back through these abdominal fascial layers. If I follow that posterior rectus sheath up, well, first of all, let's go back to the anterior rectus sheath. If I follow the anterior rectus sheath, part of the stomach channel, that's going to go superficial to the rib cage. So I'm looking up at the diaphragm. There's the xiphoid process. The stomach channel would go on the anterior surface of the rib cage. If I'm following that posterior rectus sheath up, that's going to blend in with the diaphragm. So it's a different layer, only separated by, an inch, inch and a half, 2 inches, pretty small distance. But it makes a big difference internally if I'm going deep to the rib cage and wrapping around to the back versus going superficial to the rib cage. So this is my interpretation with the spleen sinew channel. It connects with that rib cage. Connects with the diaphragm, loops around, and attaches to the spine through these attachments of the diaphragm called the crus of the diaphragm. So when I'm treating this fascial layer, I'm going to have much bigger impact on breathing, much bigger impact on spinal health also. Kidney channel, the kidney sinew channel doesn't really travel through the abdomen, so I didn't use that image, but there's a lot of discussion with the kidney channel of how it loops into this region of related fascia. Especially with the lower rectus abdominis, it has a lot of connections into the pelvic floor, through the abdominal layers into the multifidi. This is the low connecting channel. It talks about that channel coming up that layer we're talking about, posterior rectus sheath, following the kidney channel to a point just below the pericardium. Well, the pericardium sits right on top of the diaphragm. So that's exactly what it does. It comes to a point right to the just below the pericardium, and then it loops around into the lumbar spine. So, like I said, a lot of anatomy, you don't have to get in the weeds with it, but there's much more of a connection with the diaphragm, much more connection with the pelvic floor, much more of a connection with the lumbar spine when we're treating that posterior rectus sheath. That's the take home. So let's look at some pain patterns that are common when you're treating the rectus abdominis. We looked at this one with the stomach channel also because you could get trigger point formation in the belly of the muscle or at stomach 25 and this tendinous inscription between bundles of muscle. But very frequently when there's dysfunction here, it's more on the edge of the muscle at that semilunar line, maybe a little bit of the obliques, maybe a little bit of the rectus abdominis fascia. It's like a triad between the muscle groups of the obliques, rectus abdominis, and that fascial seam where all of that fascia comes together. That can be a very prominent area for trigger point formation that can give a very gassy, distended feeling when you palpate it. Maybe that's what patients are complaining about. They often want to stretch that area. Sometimes that can refer all around to the back. It can refer deep into the pelvis. It can kind of feel like it's internal in the pelvis. It's a pretty broad distribution of pain that patients might either complain about or it might be a component of their low back pain, for instance, or distension, bloating, etc. So along the spleen channel is the very frequent aspect of where these trigger points form. Anywhere from spleen 15 to about level with stomach 27 is pretty common. So you're feeling at that semilunar line, feeling for fibrosity. I usually push a little into the edge of the rectus abdominis. Another region where there's common trigger point formation would be the medial edge. Now we're at the kidney channel. So if I'm at that medial edge, it's like I can scoop deep to the muscle and, I'm palpating slightly into the rectus abdominis, but I'm really feeling more for that posterior rectus sheath. It's like I'm going through that medial edge to get to the posterior rectus sheath. I can direct into the rectus abdominis itself, or I can direct into the linea alba along the Ren channel. And same thing, a lot of pain, especially below the belly button, umbilicus, maybe halfway between the pubis and the umbilicus is a common region. It's not going to always be exact, but along that kidney distribution is a very common area of trigger point formation for deep abdominal pain, especially abdominal pain that's related to menstrual pain, dysmenorrhea. So for those patients who are having very difficult sensations during menstruation, this is a key area to look at. You also have this parameatus muscle, which attaches to the linea alba. That's going to be at the lower kind of kidney 11 region that you'd have access to that. That can give a certain amount of pain in that abdominal area that can spread up to the umbilicus. The lower portions, we talked about this one with the stomach channel, could be at the lateral edge along the stomach channel because this muscle narrows quite a bit as it gets to the pubic bone. There's not a whole lot of space on the muscle left here at the pubic bone, but really often it's in that mid-belly, just off the linea alba. That's where you frequently get this deep radiation bilaterally into the lumbar spine and iliac crest region that can be its own pain pattern, driving lumbar pain, but it might also be a component of things like lumbar facet pain. So very, very important area to palpate, usually just above the pubic bone. Sometimes you even have to press the muscle into the kind of pressing it into the pubic bone to elicit this sensation. But it's a common area where there's trigger point formation that could be a big component of lumbar pain that you wouldn't necessarily think if you didn't know the referral patterns. Obviously, you'd be palpating in the iliac crest, gluteal muscle, sacral area, lumbar spine. There might also be trigger point formation there because of its communication front to back, but don't forget about this area. All right, just a good netter image to see that. Spleen channel runs along the lateral edge, stomach channel runs in the middle, but as I get lower down, that line of the stomach channel really takes me to the lateral edge of the rectus abdominis. If I move over a little bit to the kidney channel, that's frequently where I'm going to find that trigger point formation right up against the pubic bone. Whoops. I'm going to go back to this muscle. The other kidney channel points will take me through that medial edge so I can get deep to the rectus abdominis and feel into that posterior rectus sheath. Spleen channel points, again, I can kind of through that lateral edge of the muscle at that union where it's going to then dive deep underneath the rectus abdominis. So any aspect that I'm needling through kidney and spleen, my tendency is to think into that posterior rectus sheath, which is slightly deeper than the muscle. So last time we looked at the motility of the stomach organ. This is looking at the kidney organ because movement in this area, if we can free the movement and control the abdominal movement, we can get that flexion extension. The kidney organ itself moves along the psoas. So as I take a deep breath in, that drives the kidney down. It creates a certain amount of rotation in the kidney also. When the exhale and the diaphragm rises, the kidneys rise with it. So there's a movement from diaphragmatic breathing that if I can open that up by working on the channels, increase breathing, that can be helpful. But it can also allow me to get a more efficient movement that can help mobilize the kidney organs, which is going to have good impact on the kidneys themselves, but also with lumbar pain and abdominal type situations that could be involved with the channels. All right, so let's look at an exercise that I do and I teach quite frequently. It's called a spinal wave. I have a video for it. I can talk through some key points. This will be on the PowerPoint. So let me get to that slide. And this is on my YouTube channel, Jingjin Movement Training. If you want to reference, I also go into more like verbal instruction on it. But this one doesn't have any narration, but I'll narrate over it. So spinal wave is engaging the rectus abdominis, lengthening it. Engaging, rib cage comes closer to the pubic bone, so posterior tilt, neutral to anterior tilt, posterior tilt, anterior tilt. Same time, that rib cage drops. So this is a different variation where I bring that wave up through the whole spine and chest opens, but same spinal wave. And this video shows variations with the arms and sending that energy out the arms. But whether you get that aspect of the patients, that initial one with the hands-on is really the key starting position for patients. There's a rotational version, etc. So you can build on it. Like I said, there's this instruction is on my YouTube channel if you want to look at it a little bit closer. All right, so maybe I have a few moments to go over that in my studio. I'm going to exit the PowerPoint and let's back up and we'll look at that real quickly. All right, so let's look at the spinal wave. I often, when I'm working with patients, I have them put a hand, and I do it myself this way too, put a hand on the lower rib cage and put a hand just below the umbilicus. So kind of lower dantian. The hands aren't doing anything. The hands are just helping me sort of find that movement in the abdominals. So the idea is I want to initiate that movement by pulling the pelvis up in the pubic bone. So I'll take me into a posterior tilt. Rib cage descends, expand, compress, expand. So I'm using the abdominals to drive spinal motion, drive kidney motion. Inhale, I'll fill that area up. Exhale, compress, starting from the pubic bone, rib cage follows. Inhale, exhale. So you could also start this seated with patients because very frequently patients are stiff with the spine, or yourself if you're doing it for your own health. Sometimes they just want to do it with the knees, so they just kind of move the knees or they move the hips or something like that. But they have to engage the center. So pulling up the pubic bone, down the rib cage. Top hand shifts back, expand. Bottom hand shifts back, top hand shifts forward. Compress, expand. Compress, expand. So it takes control, takes practice. You're engaging the front, expanding the front. You actually engage the transverse abdominis quite a bit with this one. That's why I like this one for the kidney and spleen channels, is you're starting to engage those deeper abdominal areas, exercising, massaging, increasing circulation between the front and the back. So very nice. So thanks for checking this webinar out. Also, thank you to American Acupuncture Council. I always appreciate the opportunity to go over this information. A lot of fun for me, very exciting stuff in my mind. So hope you enjoyed it, and I will see you guys another time.